Good. So, طيب. So I'll start. أول حاجة, thank you, Dr. Osama, for this organization. And the topic you chose is practical because we need to bridge between surgery and interventional approaches to this complex pathology, which is aneurysms. Do you hear me all okay, or there is an issue with the sound? Hello?
Hello.
Yeah, do you hear me okay, or Dr. Osama? Hello?
We can hear you well.
Okay, so I'll continue. All right. So, this is like an introduction. Well, we have few introductory slides, and then we'll go through the principles of aneurysm surgery, and then we'll go for some of the techniques that we can use in coiling aneurysms to facilitate safety and efficacy of the treatment. So this is a simple principle. The clip is applied to the neck, and from the endovascular therapy, the simplest thing is to apply the coils within the lumen of the aneurysm and obliterating the neck and preserving the parent vessel. Now, what is guiding our practice in terms of what is better, whether surgery or endovascular therapy, is few of the studies that are internationally known and recognized. International Subarachnoid Trial, the ISAT trial, and the Clarity trial from France, and the BRAT trial from Phoenix, Arizona, Barrow Neurological Institute, which kind of favored surgery. But if we look at the guidelines, the emphasis, in fact, is that both treatments are equal, they're effective, and the coiling first is recommended for both ruptured and non-ruptured aneurysm. And I think this is for a physiological reason. The patient will tolerate the shorter anesthesia and less stress of coiling rather than the surgical intervention. But the problem with these guidelines are that they are based on studies from the 90s and early 2000s. So if one is faced with an anterior circulation aneurysm, then surgery can be interesting. But if we are talking about the posterior circulation, it is more demanding surgically. That's why the interventional arm becomes more of the norm to proceed with the treatment. But there are a few things that we have to keep in mind. When people talk about cost effectiveness, the emphasis is that surgery has an upfront cost and higher morbidity. But when people look at 2 years, 5 years out of the treatment, the difference becomes negligible because of the longevity of the follow-up required with interventional therapy. You need to follow up the patient with angiogram every now and then, MRIs, MRAs, and then if there is any recurrence, you need to treat it. But with the surgery, it's a one-stop shop. You do everything and it's done, and you have to follow the patient for a shorter period of time. So the cost is not convincing. The other thing that I really don't like when you see the literature is that people are talking about differences in outcome. Like this paper in Neurosurgery in 2018, where actually they concluded that coiling after subarachnoid hemorrhage is associated with increased 14-day case fatality as compared to clipping. And I always wonder that why could someone do this and draw a conclusion that clipping is safer, while in fact the patients who are designated for coiling are usually the worst patients. So I don't think we have to be biased with any of the interventions, either coiling or clipping. We have to just decide for an individual patient what is best for them. Because here you can see patient 1, 2, and 3 could be anything. They could be grade 1 subarachnoid hemorrhage, they could be grade 4 subarachnoid hemorrhage. Patient number 4 is definitely a bad one. No doubt about that. But 1, 2, and 3, they could be anything. So we cannot really base the decision on a scan or on what the international trial with thousands of patients said. We have to make a decision based on the individual patient we are treating. I'll skip this for the sake of time. So in 2019, going into 2020, I think the treatment paradigm should shift from what we can do as physicians to what the patient needs as an individual. So it's not about MCA clipping versus coiling, it's clipping or coiling or combined approach, if you may. So that is what we have to go to change our mentality when we come to aneurysms, like moving forward. This is an example of an MCA aneurysm that I treated in our hospital. MCA aneurysms, by default, it's in the blood of neurosurgeons that this is an aneurysm that is treated surgically. I mean, it's simple coiling did the job here. This is another one, same location, ugly looking aneurysm in a 27-year-old lady who's a housemaid, grade 2 subarachnoid hemorrhage with an evidence of a rebleed in her clinical course. So here one can entertain multiple options of treatment, but one major issue here for her as a patient is that she's an expat and her sponsor will send her home to her country with no prospect of follow-up or longevity of follow-up for that matter. So we can entertain doing something elaborate with one stent or two stent or Y stent, but what if she goes to her country and she cannot be followed? So here it begs the question that what are the basic principles of aneurysm surgery? Obtain proximal control early. We can do that because the M1 is long. The first M1 segment is long. We can preserve the perforators because there is no major hematoma that we have to go through. And attack the neck first. So we can see that although it's an ugly looking aneurysm, the neck is still preserved, and we can avoid attacking the dome or approaching the dome before we approach the neck for proximal control and risking a bleed. So here, two clips were one straight and one curved, and a clip wrap on the fusiform lobe into the superior branch of the N2. Did the job, and the aneurysm is occluded, and she is practically cured. So all she needs is a follow-up non-invasive imaging, and that will last for 3 years, and if she's done, she's done. If there is any recurrence, then one can anticipate it. But if we did an elaborate surgery, then we had elaborate endovascular therapy, we would needed a heavy-duty follow-up and long-term follow-up angiographically, which might not be possible for this particular patient. Sometimes we have sick patients with subarachnoid hemorrhage, like a 42-year-old with a grade 4 subarachnoid hemorrhage with myocardial stunning due to her subarachnoid hemorrhage. She's currently on inotropic support, and she has a horrible tight brain, and the surgeons are afraid to operate on this. So what do? So she's not good for surgery. She's really sick. Anytime you move her from bed for scan even, she goes into hypertension, so let alone going for surgery. So we can say that it's futile, we don't treat, we have to pray for her, we go for surgery regardless, or attempt endovascular therapy and pray. So here what one can do is just to secure the fundus, which is most likely the area of the bleed, and then that becomes a win-win situation because the bleeding point is secured. Now we can let her rest for the rest of her acute phase, and then come in and do the clipping when she's in a better shape, or even entertain a stent-assisted coiling for this particular location. So here it's important to consider the partial coiling as a safety measure in facing of an acute rupture of an aneurysm with high-grade subarachnoid hemorrhage. We can use things like balloons to help us increase the safety, because sometimes the perfect solution is a stent-assisted coiling, but you don't want to go through the dual antiplatelets in the acute phase, especially if the patient might end up for surgery for an external ventricular drain or even clipping. So balloon-assisted coiling becomes a real adjunct to our advantage. So this is a patient with FAR disease, bilateral calcification of the basal ganglia, and he developed a subarachnoid hemorrhage from this aneurysm. It's a kind of oblong shape, narrow, not a narrow neck that one might think would require clipping. But while the patient was awake, in fact, we managed to get the microcatheter into the aneurysm, and the 3D coils kept kicking either the microcatheter out or they come out themselves. So we resorted to the old school aneurysm coils, which are the helical ones that people tend to forget they exist, and they did the job perfectly. So you can see that without even any assisted device, the helical coil framed the aneurysm very well, and another aneurysm just occluded it. Another coil, sorry, occluded it. So that is what we have to do, and sometimes you need to remember that all the material on the shelf are applicable to these treatments. Dual microcatheter is something intriguing, that you offset the need for the balloon. If you don't have one, you can put the two microcatheters in a wide neck aneurysm and let the coils mingle with each other and stay within the lumen of the aneurysm. The microcatheter repositioning is something that is really important, and I'll just demonstrate here with a couple of videos. This is an aneurysm that is wide, but large as well. So we have the advantage of maneuverability of the microcatheter within the aneurysm. So here I'll show you the video first to see what the coil is doing while we're advancing it. It just keep going to the A2 segment. This is from the lateral view, and you can see that again the coil will just make the first loop and then go to the A2. So here I want you to pay attention to what's going on to the microcatheter, because here this is the coil going into the A2. Sorry, you will hear my voice in the background, ignore that. So now at this point you can see the pressure build up here in the loops of the microcatheter, and then the tip of the microcatheter will move within the aneurysm. Now the coil goes and gets restrained with the microcatheter at the neck, and then it bounces within the aneurysm, and we can complete the procedure like that. So sometimes just knowing that the microcatheter advancement can help you, then you can offset the balloon altogether. Here the balloon microcatheter is not inflated, it was just parked in position, and the coiling was completed, and everything went well for this particular patient, so without even inflating the balloon. The balloon could be a wide balloon for wide neck aneurysms, or a hyper-compliant balloon which can push the neck, to push the coils within the neck of the aneurysm to increase the chance for preservation of the neck of the aneurysm and the parent vessel. So here, like in this particular A, you can see that there is protection of a branch coming very close to the neck of the aneurysm. I'll skip this one, and here you can see dual lumen balloon, where the coiling and the balloon inflation happen in the same microcatheter. That's a good advantage to minimize the hardware in the patient and maintain focus during the procedure. Cross circulation is something that sometimes we have to resort to, especially in complex anatomy. So it's something that you need to understand and apply from time to time. So in the middle image on the right side, you can see that there is a balloon from the right vert to the left pica, and the microcatheter coming from the left into the aneurysm to deploy the coils. This is another way to do it through the PCOM, and this is the ultimate, where you have a balloon, Y configuration of balloons with the third microcatheter in the aneurysm for coiling. This is, now we're shifting to surgery, and I don't know who is a surgeon in the group, but now you might start paying attention, because ACOM, they're not all the same, because here the anatomy of ACOM, for example, is different from one patient to the other. And it's very, very important that we study this ahead of time so we can know whether to come from the right side, from the left side, or at least subfrontal to obviate the need for any lateral approach to any of these aneurysms. Because this is the source of problem. The top one is the best one because the aneurysm is secured by the clip. But in every other possibility, you can see that the aneurysms might recur because there is a remnant of the aneurysm neck that is not covered by the clip, and here where you need a booster clip or a small clip or readjust the clip altogether. Sometimes you need simple clipping, sometimes you need stacking of clipping or overlapping of clipping, fenestrated clipping. That is all something that comes to you when you're in the field. You can see it, but you have to anticipate that ahead of time. If worse comes to worse and you're stuck with a remnant, then you can do the clipping and then you add wrapping around the remnant, and that will offer some protection rather than leaving it alone and risking a rebleed. So sometimes clip stacking is an important thing, especially if there is a preservation of a vessel that is necessary. So here, like you can see that this is an MCA bifurcation aneurysm, but unfortunately, the superior M2 is coming from the aneurysm lumen. So a simple clipping here would have killed this superior branch of M2, and the only way to do this is by multiple clipping. And you can see here on the right side with a little bit of a pixel shift, you see we put 3 clips to preserve the superior branch and at the same time obliterate the neck of anners. Sometimes residents jinx the cases by saying that this is a simple PCOM, and look at what happened. Once the clip was applied, the artery went into severe spasm. So this is something that we have to deal with on the spot. And what we can do is massage the artery with a bipolar forceps, and that might open up the spasm. If it's still persistent and you can see the artery is small, you can inject piperine in the field, but that will lead to pupil dilatation, so we have to be careful with that. Temporarily, of course, but one does not panic when we remove the drapes of the patient. And we can give melanone intraarterially or intravenously to maintain the opening of the vessel. Sometimes we are faced with multiple aneurysms or mirror aneurysms, and we have to keep an eye on this and plan our surgery accordingly. So this is a patient, we have an MCA and another MCA, and you can see the clips are having weird orientations, because if we do a good job in the opening and we drill the sphenoid ridge and have a good subfrontal exposure, then you can see the 2 optic nerves, and you can see the contralateral MCA and the ipsilateral internal carotid and the bifurcation as well. One of the nightmares that we deal with are blister aneurysms, and these are problematic because they don't lend themselves very well to endovascular therapy. There is a very high risk of bleeding and rupture when the microcatheter goes into them. Flow divergent safety might be questionable if you leave the patient with dual antiplatelets for a period of time before deploying the stent. The acute loading of dual antiplatelets in this setting might not be advisable. So we have to be very careful when we select which patient for which treatment modality we're going to use for each patient, or which patient I mean. So in the surgical principle for these, this is like a little blister. Actually, we were going for an MCA in this one, and we found this blister in the internal carotid artery. So here what you're going to see is a series of images to show you how the clip is going to progress when we're treating this. So the clip now is parallel to the lumen of the wall of the vessel. Then it gets smaller and smaller and smaller, keeping part of the wall within the blades of the clip. So that is the key to the successful treatment and safe treatment. Otherwise, we'll avulse the blister, and the patient will have a hole in his artery, and that will be sometimes difficult to repair. And this is the end result. So you see at that, there is part of the normal wall going within the clip blades, and the aneurysm is secure. So this is obviously an MCA aneurysm within the bleed strictly within the sylvian fissure. and this is what it looks like. So you can entertain multiple things, but in this particular patient, we went for surgery, and this is what happened. As expected, once the subarachnoid space is open, the aneurysm just burst. So here, this is like a catastrophe that can happen in the surgery, and that's why a lot of neurosurgeons don't like to clip aneurysms, because this can happen and one can lose control and might lose the patient because of this procedure, or because of this event during the procedure. So what to do? First of all, no one should panic. The anesthetist should get the blood for the patient, drop the blood pressure even to the lowest that they can, and there should be minimum 2 sections in the field, one to remove the excess of blood, and the other one to find the puncture point and stay on it till a clip is applied on it to protect from further bleeding. Sometimes we cannot do that, so we have to put a clip on the temporary, like here you can see that there is the suction in the puncture point, and we have a temporary clip already applied in M1, but it's not doing anything. So now we put a quick clipping on the neck of the aneurysm. Hopefully it will secure it, and that's what happened. And you can see we're removing the temporary clip from the moment. So that is something that you have to anticipate and plan for, and the team has to be aware and ready for something like this. And in fact, when I treat patients like this, I have to alert the anesthetist from the beginning of the case that this can happen. And if it's a complex aneurysm that we're worried, we actually prepare the patient for the adenosine cardiac arrest, and I'll show you this in the next couple of slides. So here what happens is that, sorry, we're starting here with the rapid ventricular pacing. So instead of having the adenosine arrest, sometimes we can do the rapid ventricular pacing. So the pulse, you can see it's going to 180, creating some sort of a lack of filling of the ventricle, and that will soften the aneurysm and reduce the bleeding, and allow us to apply the clip on the aneurysm and secure it, and then there will be immediate reversal of this ventricular pacing. The other way is the adenosine arrest. So here you see on the left side, you can see normal sinus rhythm, and then the patient will receive the dose of adenosine, and they'll be literally asystole for about 40 seconds, and then the heartbeat will come back on its own. So during those 40 seconds, it gives us more than enough time to separate the perforators from the neck of the aneurysm and apply the clip safely, and that will do the job most of the time. So here you can see that we not only do it for catastrophe, we can actually do it as part of the procedure to facilitate the dissection, and instead of spending 2 hours trying to work around the tense aneurysm, we soften it by one of these maneuvers, and that will cut the time significantly. What can we do in terms of the surgical approach to help us confirm our obliteration of the aneurysm? We can use indocyanine green, which is a fluorescent dye during the surgery. So this is a posterior communicating artery aneurysm. So you see then the posterior communicating artery, and then there is the aneurysm next to it. I don't know if you see any arrows here, but in the screen, but there are arrows that are pointing to where the aneurysm is. So now this is the ICG before the clipping. You see the hump of the posterior communicating artery, and followed by the aneurysm where the arrow is. And this is after the clip is applied. The PCOM is off the aneurysm clips, and the aneurysm seems to be secured. Now we confirm with the ICG, and you see that the PCOM has the flow and no aneurysm, no filling in the aneurysm is seen. Sometimes this is like again a clip reconstruction of an MCA complex one, and multiple clips are applied, and now we want to ensure the patency of the superior branch, and we do the ICG, and you can see the loop of the superior branch intact with all its branches like it was before the clip was applied. So this is the advantage. You can confirm this during the surgery, and it becomes a question whether you need an angiogram later on or not, but for all practical purposes, we do the angiogram anyway for long-term follow-up for the patient. So to summarize the principles of simplifying the INR procedure, because I mean you don't want something to shorten your lifespan, you want something to make it practical and safe for the patient. So we can use the aneurysm, especially big ones, to make them smaller, or we can use the balloons to make the coil mass away, deposit away from the parent vessel, and that will help with the safety of the coiling. Partial coiling sometimes it's better than complete coiling and risking parent vessel occlusion, and then you have to go for surgery and push for it. Framing coil with helical coils might be needed sometimes. If the arteries are shattered, sometimes parent vessel occlusion is better than risking dual antiplatelets in the acute phase and having the patient die from a massive bleed. And sometimes if you're facing too complex of a procedure with multiple balloons, multiple catheters, and a lot of contingency for a lot of problems happening, maybe surgery is the better option for the patient. And now when we talk the surgery, you notice that I will put the first thing is partial coiling. So if the patient is too sick to undergo a surgery, don't be a hero. Just do the partial coiling, secure the aneurysm at that stage, and then you have time to think. The patient will get better. The patient will tolerate longer procedure. You're not operating under stress. Everybody in the team is relaxed when you do something like this. So it's better to time the surgery and use partial coiling as a tool to improve the safety of your own clipping later on. Adhere to aneurysm surgery. There is no need to do shortcuts. You have to obtain good opening, proximal control early, and the, the aim of the surgery is to obtain proximal control to the perforators and get to the neck first. Um, it requires good surgical dissection, so that is what most of the time of the surgery is going to be spent on. To apply a clip, it takes about 10 minutes, but to get to the aneurysm safely, it takes about 2 hours. So that is what we have to spend more time on. It's not really a bragging point that I did an aneurysm in 1 hour, but that patient ended up with like 7 contusions and 2 intraoperative ruptures. And one can utilize skull-based approaches, drilling of the bone, and
يا بنت اسكتي، انا بسمع حاجه مهمه.
retraction. And the less retraction, the better, because classical teaching tells you to put retractors, and that can risk ischemia to the cortex or even rupture of an aneurysm if you're not with the
انا
clip,
بسمع في
with
محاضره على النت
with the
بسمعها
retractor.
شغاله دلوقتي.
So one final word of advice. If we're working together in a hospital where there is an interventional arm and a surgical arm, we have to be careful of what working model we're going to choose. We can be either like little children, one arm is better than the other, or like either this or that. And I hear people brag about, there was no clipping in my hospital done for the last 7 years. Well, I don't really get impressed with this. We have to be careful and on what we are choosing for our patients. Sometimes people are bullying each other. The surgeons blame the interventionists blame the neurosurgeons. Sometimes one think that they are better than the other, but they allowed them to do their job anyway. But I think the best thing is that we work together in equality. We discuss the cases together, leave our egos at the door, and go into the discussion with the patient in mind, and that will make us make practical decision and enjoy what we're doing, and more importantly, to sustain our work beyond our time. So with that, I conclude and take time to question. I thank all my team for their hard work and my family for their sacrifice. And I take questions now if you have any. Thank you very much.
Thank you so much, Dr. Hosam, for your, as usual, illustrative and very informative, comprehensive, and innovative lecture. Actually, what was fascinating learning point is that the message that come from your presentation, that the coiling and the clipping are not competitive, and they are complementary, procedure, and we lose our compass when we are thinking in a more procedural or operator-centric way rather than patient-centric way. And I think this is why most of us are losing the compass when we use such way of thinking. And we should work as a team for finding the proper treatment for the patient, not for the operator or for the procedure. And I think it's a very fantastic lectures, very illustrative and learning lecture. And I know that you have a flight to catch now, but I have a question.
Yeah, sure, go ahead. I still have time, don't worry.
Okay, so from your experience, how frequently you are using the surgical approach for treating the blister aneurysm, and on the other side, the endovascular approach for treating the MCA aneurysm?
Yeah, so from like the MCA aneurysm, I have to admit that I do more clipping than coiling in these patients. But again, if I'm going to put a number on it, I would say that 70% to 80% are clipped and 20 to 30% that are coiled. But that is my personal experience. But I will always present the endovascular therapy as an option. And we talk about the patient age, the patient need for medication, and so on and so forth. And I will always have this discussion as equal arms as you mentioned. For the blister, I like to treat them surgically. It's just I've never done a blister aneurysm with endovascular therapy. But I know the literature that shows safety and efficacy of flow diverting stents, because you don't want to stick a microcatheter in the blister aneurysm. I never objected to that, but I never found myself doing it for the lack of the patients themselves. Like like the blister I showed you, it was actually found on the way to an MCA, so that was not an intention. The intention was to clip the MCA aneurysm, and we found this on our way in the internal carotid artery. But if I have a patient who is sick, and let's say they came out of their subarachnoid hemorrhage with poor condition, and we're afraid they're going to die, I'm not going to take a patient who's barely recovered from a subarachnoid hemorrhage through the hell of surgery. I will just load them with dual antiplatelets for sufficient amount of time and go for a flow diverting stent. So I still have the two options even for blister aneurysms, although I have never done flow diverting stent for one of them.
Okay, thank you.
I hope I answered your question. Sorry.
Yes, certainly. Okay. So, anyone have a question?
Okay.
So, I have another question.
Go ahead.
Yeah. I think it's when we look at the literatures and the revolutionary movement of the treatment, endovascular treatment of the aneurysm, the man can lose his way during moving from one treatment option to another treatment option. For example, the flow diverter, the parent artery flow diverter, the intrasaccular flow diversion concept to the neck, at the neck flow diversion devices, and so many breakthrough in the industry regarding the armamentarium for the endovascular treatment of the aneurysm. Do you have the feeling that we need to have something like our protocol for our area or for our region? Because in the Western countries the situation is totally different, because most of the patients are covered by medical insurance, and the money is nothing behind the quality of life of the patient, and so they are doing their best to do something which could be better than another thing. But in our country, do you think that we should have something like a protocol that can be unified, the protocol taking into consideration the economical issue in our country for our patient?
Yeah, certainly. I will take us a step back in terms of the drive for flow diversion. I think this is something that we also have to include in our discussion about the training, because if people are trained a lot with flow diverters, they're not going to be able to manage microcatheter manipulation inside aneurysm. So this is something very important to consider when we're talking about the safety of our future generation of interventionists, that if the flow diverter dominates, then they will not be able to do the microcatheter manipulation in an appropriate way. Now let's move forward. When there are people who can do the job, having the flow diversion is, as you put it, it's portrayed like the ultimate and the most advanced treatment. But in our part of the world, where the budgets are limited, I think there is an obligation for us to be rational. So, like a PCOM, the one I showed you, it was treated by a couple of coils. Why would one entertain putting a flow diverter in that aneurysm from the beginning? You can put 2 coils, and that's it. It's done. We don't need to go through the budget and through everything. Now, mind you that the coils, if they recur, you can still recoil, or you can put a flow diverter. So I agree with the, at least from my place and other places that I collaborate with, we have adopted this kind of approach that we do the simple coiling or balloon assisted. If there is a recurrence, then we will consider the flow diverter. It's very rarely that we talk to the patient about the flow diversion from the beginning, unless it's an unruptured aneurysm with a very wide and complex morphology. Then one would tell them, okay, you know what, we'll put the flow diverter with or without coiling. But in the acute cases, the ruptured cases, you don't need to add complexity to it, first of all, and you don't want to add a lot of cost at the beginning, because some patients are paying out of their pocket, or the hospital is getting burden. So it is important to put that in mind. So I would agree to put sort of a working framework to do the simple or simple coiling or balloon assisted coiling first, and leave the flow diversion as a second phase, because that will work for everyone.
Okay.
Okay. So, any other comments or questions from the participants?
Yeah.
Who's still with us here? And read their names. Okay.
Okay. Thank you, Dr. Hosam, for your
We'll see you, inshallah.
And I think
Okay.
I know that you are very busy now to catch your flight.
Yeah.
I think.
Okay.
Well, we wish you a safe flight.
Thank you. Thank you very much.
Thank you so much, and see you soon, inshallah.
Thank you. Assalamu alaikum.
Thank you so much.